Hello everyone, my name is Caitlin Martin, and I'm going to be talking to you today about outpatient management of substance use disorders with a focus on alcohol, opioid, and stimulant use disorders. And in addition, we're going to be talking about how the management of these substance use disorders does vary during pregnancy. Just to give a little background about myself, I work at Virginia Commonwealth University in Richmond, Virginia, and here I practice as an OBGYN as well as an addiction medicine provider. And in doing so, I lead our program that we have here for women with substance use disorders, where we offer integrated OBGYN and substance use disorder treatment care in addition to wraparound services. And I lead a large multidisciplinary team here with that. I have no disclosures. And so the outline for the presentation today is that we're first going to talk about the epidemiology of substance use disorders with a focus on how those vary by sex and gender, including across the life course with regards to pregnancy. We're then going to spend the first half of the presentation talking about SBIRT, or screening, brief intervention, and referral to treatment as a paradigm for which we can initiate and manage patients with substance use disorders who come into our practice. Next, we're going to talk about outpatient management, including how to tailor treatments during pregnancy and postpartum for alcohol, opioid, and stimulant use disorders. And in doing so, we're going to be focusing on the medications that we do have for these substance use disorders, which of course are offered in addition to behavioral health therapies. So let's jump right in. So first, we're going to be talking about the epidemiology of substance use disorders. And the big take-home point I want to bring away from this epidemiology section is that it's not just an opioid crisis that we're dealing with these days. This is a paper that came out in 2019 looking at the life expectancy and mortality rates in the United States. And they also looked at them by cause of death, as also by age, race, ethnicity, sex, etc. And what they found is that despite all the great advances we've had in medical care over the last decades for people's health, long-term as well as in the short term, that we've seen decreases in the life expectancy with these advancements. Unfortunately, in the last few years, we have seen a decrease in life expectancy. We have been seeing increases in life expectancy from all the advancements for medical care and addressing social determinants of health. But sadly, in the last few years, we have seen a decrease in life expectancy. And the big driver of this decrease in life expectancy has been the huge increase we've seen in substance use related deaths. And what's pretty remarkable in a sad way is that these stark increases in substance use related deaths have largely been among young people, as you can see here from a couple figures from this paper. And what they did find in some of the subgroup analyses in this paper was some disparities across different groups. One of the disparities that they did found was for when they're looking at males and females, they did find a pronounced female disadvantage, they said, for certain causes of death, including those related to substance use, like drug-induced deaths, like related to opioids, as well as alcohol-related deaths. And seeing that even though at the absolute number of males are dying from substance use-related deaths than females at one point in time, if we look at the rate of change over time, unfortunately, the increase that we've been seeing in substance use-related deaths has been rising more rapidly for females than it has for males, showing that the gap between males and females in the role that substance use plays in their health, including morbidity and mortality, is narrowing. And in addition to that, they also saw some racial and ethnic disparities that we'll be highlighting in some other literature too coming up soon. And so again, it's not just the opioid. And so unfortunately, amphetamines, in particular methamphetamines and also cocaine, that use has been increasing too in recent years. And they did see some of that in the prior paper too. This is another reference here that was published just recently, looking at methamphetamine overdose deaths in the United States. Again, looking at men and women, or males and females, over time. And you can also see, again, this increase that we're seeing over time in methamphetamine-related deaths. And that's been occurring across different racial and ethnic groups in addition to that. So again, seeing that substance use, including opioids, methamphetamines, alcohol, etc., do play a significant role in the overall health of many individuals in our country. And again, in addition to the disparities that we've been seeing by sex and that narrowing of the gap in the role that substance use plays in morbidity and mortality between males and females, we're also seeing, unfortunately, a narrowing the gap in the role in the disparities by race and ethnicity. This is a very recent paper that came out looking at how Black and white people are differ in the rate of change in opioids related to their mortality rates. And what's interesting and what this paper does bring about with data is that, historically we thought of the quote opioid crisis as mainly a white person problem, and that it got a lot of attention, a lot of traction when the opioid crisis first started being in the news and in the media, and got the word crisis and epidemic because it was rampant in the white population, even though Black people have been dying from opioid related deaths for many, many years. And unfortunately, that disparity or that difference between white and Blacks at the beginning of the quote opioid crisis, unfortunately, is also narrowing too. And recent data is actually showing that, as you can see here from this graph, that the rate of change in mortality related to opioids is actually become higher in Black individuals than white individuals if we're looking at the rate of change. And again, these trends are showing where we're going with regards to what substances are playing the most significant roles on a public health space for our patients that are coming into our clinics. And unfortunately, in this paper, the findings, when they broke it down by state, did not show that our state, Virginia, is doing very well. So this is one table from that paper, which looked at the average annual percentage change. So essentially looking at what the proportion of change that opioid-related deaths are having on these different subgroups when they looked at Black people compared to white people, and looked at the absolute difference in that rate of change. And as you can see here at the beginning-ish of the opioid crisis, Black people were dying less commonly than white people. Again, looking at the rate of change over this period of time from 1999 to 2010. But once we start going further into the most recent time frame, starting in 2010 all the way to 2018, the numbers flipped, showing that the rate of change with regards to opioid-related deaths is occurring more rapidly for Black people than it is for white people. Essentially showing too that the role that opioids is having, role that opioids are having in the health and morbidity and mortality of our patients transcends across race, ethnicity, sex, and gender identity. And so some of the most recent data that we can use to look at trends on a public health level with regards to substance use related morbidity and mortality are from the CDC. So this is an area that you can Google it, and you can go to the CDC website that has the provisional drug overdose death counts. So essentially the most recent data that we and the lay public can have access to see what the landscape of the public health public health landscape looks like for drug-induced deaths. And the reason I'm bringing up this slide is that the COVID-19 pandemic has had significant impacts on many, many people, including especially the most vulnerable populations. And I'm going to include people with substance use disorders in that category. And there's been many papers and many research studies that have come out looking at the adverse impacts that the COVID-19 pandemic has had, just further accelerating the morbidity and mortality that these individuals suffer from. And so again, you can see in the most recent data here in this 2020 up here in from the CDC, this is just for Virginia, that there's been an even higher increase in drug overdose deaths in our own state, as you can see from the numbers here. And again, what's interesting with the CDC data is that we can see it broken down by substance to the extent that the data allows us to do so. And so this is the same trend that we were just seeing of that overall huge uptick in drug-induced deaths in our state of Virginia in the COVID-19 pandemic in this 2020 calendar year area over here. And we can see here, of course, opioids in black here are still playing a significant role, of course, in these drug overdose deaths. But you're starting to see See, in addition to that synthetic opioids, fentanyl is a huge problem that we're seeing nationwide, including in the state of Virginia, and contributing significantly to this a further increase in the rise of overdose deaths. But you're also starting to see trends down here too with the stimulants. So this is cocaine here in pink, just showing again this gradual trend, and it continued through the COVID-19 pandemic. Is also the same trend is following too for methamphetamines down here. Again, showing it's not just the opioids. Opioids are a significant problem in our country, but other substances too are playing significant roles. And then when we're talking about disparities, there's disparities across multiple groups. I've shown you data by race and ethnicity, and also by sex. And you're looking further across the life course for individuals. For females, as one example, we have to consider how substances play in morbidity and mortality and the health of this population. And for females, given that substance use disorder is a chronic medical condition, it extends into pregnancy, just like every other chronic disease like diabetes, hypertension does too. And so there's been multiple papers pretty much on statewide data that's been showing that the role that drug-induced deaths or substance use is playing now in the morbidity and mortality of these women during pregnancy is now surpassing all the traditional areas that we've thought of. So this is some data that came out from Colorado a few years ago, and they looked at the certain drug-induced deaths during their study time frame, and they found that deaths due to mental health and behavioral health causes such as substance use and suicide outpaced all these other causes of death. And that's very important because me as an obstetrician gynecologist, I was very well trained in hypertensive diseases of pregnancy, postpartum hemorrhage. I'm ready for that. I got very good training in that. But did I get amazing training in how to assess and treat and address substance use and behavioral health causes within the context of what I also do as a provider, as an OBGYN? No. And that's a huge problem given the crises that we're facing these days as providers, and that we really can't ignore the role that mental and behavioral health can have on our patients overall. And again, just bringing home the point that it's not just the opioid, there's many other substances. In this paper in particular, alcohol was number 2 of the number of when you're looking at all the substances that were involved in these terrible deaths in the state. And again, looking across the life course for females assigned at birth who then become pregnant, these drug-induced deaths we're seeing, again, opioids and along with other causes, they're occurring during pregnancy, but they're actually largely occurring in the postpartum period. So you can see here, this is data from Utah. Again, state level data is kind of giving us the best snapshot of what's happening across pregnancy and postpartum for substance use related deaths. And you can see here there were some drug-induced deaths in the pregnancy time frame, but you see go to postpartum and it's a huge uptick. And you see here it's in that latter aspect of the postpartum period, which is really important to know because this is typically after patients have left the care of the OBGYN. Of course, how postpartum care is being administered is changing. There's a huge call for the quote 4th trimester that extends from 3 to 12 months postpartum, which will include heightened care and heightened attention by OBGYNs and other women's healthcare providers for these very reasons, that there's many medical conditions that extend outside the pregnancy, the typical pregnancy window that we've thought about. But again, honing in the point of the importance of these women being extremely higher risk when they're already in a vulnerable area for substance use causing significant morbidity and mortality. And again, it's not just the opioid. There's many other substances that are playing a role in this. And just to bring that point home that I brought up at the beginning, these are just some snapshots of some other data that comes out showing us the role that different substances are playing in the health of pregnant and postpartum women. Okay, so next, let's start talking about ESPER. What do we do with all these terrible numbers that I just brought up, showing the quite prevalent role that substance use disorders have in the health of our patients, either on a population level as well as on an individual level when they're coming into our offices? Well, it all starts with knowing what you're dealing with. You can't start management, you can't care for a patient, you can't offer that support if you don't know what's going on. And so we're going to go into SBIRT. So what does SBIRT stand for? It stands for Screening, Brief Intervention, Referral to Treatment. And so we're going to go through all of these areas for SBIRT in a general framework, as well as then go through how we particularly apply it to one of the substances that's the focus of this talk today. So we're going to be using this diagram as we work through SBIRT. I know it says during pregnancy up here, but I like the way that this is formatted, and I think it's important for us to consider this flow diagram when we're thinking about how to screen, assess, and manage our patient with brief interventions and referral to treatment. So we're first going to start with screening. How do you screen for risky substance use or substance use disorders? Well, we're going to go over some validated tools, and that is the recommendation. Validated tools, there's many screening tools that have been validated in many populations that are very easy to administer in the office. And so we're going to go over that. How often should you screen? Well, there's differing recommendations by the United States Preventative Services Task Force and other professional societies. In general, I would recommend that all patients should be screened at all their preventative healthcare visits, which for me as a gynecologist refers to the annual well woman exam, as well as when patients come in for pregnancy-related visits. But of course, if you have patients coming in more often, then you should be consider doing it more than once a year. Selective screening based on risk factors is not effective. You will definitely miss patients if you only screen them on typical risk factors that we learned about, in medical school and the USMLE exams and things like that. You're going to miss patients. I think I showed you from the epidemiology slides at the beginning that substance use disorders cross all different groups, race, ethnicity, sex, and we didn't go over the gender identity data, but it's quite prevalent among gender minorities too. And so we need to make sure that we are doing universal screening with validated tools for all of our patients. Now, it's very obvious that screening during pregnancy is extremely important too. And so pregnancy offers quite a unique time frame. I say that because a lot of my patients start treatment with me when they're pregnant and continue with me through the postpartum period. And pregnancy is a window of opportunity for behavioral change when we're talking about behavioral health disorders. But in order to help your patient take advantage of that opportunity, if they're at that point in the life course or in the trajectory of their disease, of the substance use disorder, you want to make sure that you're making yourself available to support her along that path. And that all starts with non-judgmental, universal, evidence-based screening. And so what are the best practices for screening? And I really can't say this enough. You need to ask patients in a non-judgmental manner about substance use. Substance use is an extremely stigmatized area. Also, substance use disorder treatments, including medication treatments, which are evidence-based and save lives, are still highly stigmatized in healthcare settings, community-based settings, legal settings, etc. And so you really have to do your best to really go against those barriers and that stigma provides between you and your patient in that exam room. And so talking to patients in first-person language, talking about their substance use in a compassionate, non-judgmental way is extremely important. Can't say it enough. And so some examples, these are basics that we learned back in medical school, but asking open-ended questions and asking permission before you start talking to patients about this sensitive topic. I know for us, it doesn't seem like it's a sensitive topic sometimes because we're providers, right? This is what we do every day, but it's not going to be like that necessarily for your patient. So there are some tools to help you along this path, help you use a validated tool, help you assess substance use disorders in an evidence-based way and in a compassionate, non-judgmental, yet comprehensive way to help you make accurate medical decisions. This is one example. I like this one because there's an online interface. These are actually screenshots from my iPhone showing the NIDA drug screening tool or the NIDA modified assist tool. And what you do is you can go through this with your patient, and actually it spits out a score at the end, and I'll show you what that looks like. And so if a patient scores anything other than never on any of these sections, then it'll open up into a longer screening tool to further assess how much that patient is using and how at risk they are of unhealthy substance use. And again, just you can go to this website for this screening tool. You can pull it up on the computer in the patient room and do it with the patient right in front of you. When you're talking about screening and pregnancy, it does get a little bit different because the time frame of pregnancy, there is a natural decrease in substance use for most women who are using substances before pregnancy. But that does not necessarily weed out all the women that remain at risk of a substance use disorder or unhealthy levels of substance use, despite the decreases that may occur for many of these women after the recognition of pregnancy. And so knowing that pregnancy does beg a difference and really tailoring not just our treatments, but also our assessments and screening tools for substance use, there have been a few studies looking at the different validated tools that we do have for substance use disorders to see, gosh, how good are they for pregnant people? And so this is one paper that looked at the assist tool, the one I just showed you that has that online interface, as well as two other tools, the 4Ps Plus and the SERP, which are both tailored specifically for pregnancy. And they look to see, gosh, how well do these tools work compared to one another in assessing and identifying patients at risk of substance use disorders? And they found that unfortunately the NIDA Quick Screen Assist does not work as well as these other tools that have been tailored to pregnancy. Why did that come up? Well, I would say that a big part of it is that the time frame of pregnancy, like I just mentioned, is not really taken into consideration with the NIDA Quick Screen that I showed earlier from the online interface. That one just refers to the past 12 months. But if for a woman, if the past 12 months includes the period of pregnancy or recognition of pregnancy, you can have some changes in your substance use patterns that are natural, but maybe patients can end up going under the radar more commonly. These are the two screening tools that were looked at in that one study. These are two of my favorites. The 4Ps Plus is copyrighted, so please make sure you don't integrate that unless you get copyrights for that into your practice, but this is what it looks like. This is the SERP here. What I like the best about these screening tools is the underlying portion here, is that they ask patients about their substance use before pregnancy as a way to open up the gate, open up the conversation. And so this is exactly what I do in my clinical practice. I never start with talking to a pregnant person and say, oh, how much alcohol do you drink? I always ask them about, before you knew about your pregnancy, how much alcohol were you drinking at that time? And I do the same thing according to the SERP, for example, here for all the different substances when I'm screening patients for unhealthy substance use. An important point for all patients, and I would argue especially parenting patients, is that toxicology tests or urine drug tests are not screens. So the only way to screen a patient for a substance use disorder is using one of these validated tools and having a provider conversation with a patient. It's not getting a drug test. And the reasons why is because there's many reasons. One is that drug tests carry a lot of advantages and they carry a lot of disadvantages. The big disadvantage that I think is easiest for us as providers to think about is that addiction is a chronic disease, right? It goes across the life course, in certain periods of time for people. Getting a test at one point in time that gives you a snapshot of how much a patient is using for drugs at one point in time is not going to give you an accurate picture about their substance use patterns. And that is what you need as a provider in order to provide accurate, comprehensive care for your patient. It's just like with blood pressure and hypertension. Taking one blood pressure in the office is great, right? It does give you information, but that is not going to hone in how you manage that patient. You're going to want to have a blood pressure log. You're going to have blood pressures over time. You're going to want to look at trends. Same thing for diabetes. Getting a glucose in the office, sure, it'll give you some information at that time, but you want to see how those sugars act over the course of a week when that patient's not in your office. You want to get a hemoglobin A1C to see how your sugar's been on average over the last 3 months. And so again, I think as providers, it just makes sense for us to treat addiction in a similar fashion in how we're assessing it. And it's big with getting trends. And for us with substance use disorders, we don't have a hemoglobin A1C necessarily that's clinically useful. It does involve a conversation with the patient. The other thing to recognize too, in addition to what I just said, which is I think the most important point on why drug tests are not good screening tools for substance use disorder, is because these drug tests carry a lot of limitations. And I would argue that you should not order a drug test unless you know the limitations of the drug test for your specific lab. So what are the sensitivities and specificities of the different substances that you're testing for using the drug test in your lab? Because it really does vary by lab. One very important thing to know is that there's two general types of tests. There's the immunoassay test. These are also called presumptive tests, point of care tests, stat tests. Sometimes they're called screening tests. Again, I don't recommend calling them screening tests because that perpetuates the idea with other providers that screening with a drug test is appropriate when it's not. It's using a validated interview tool with a patient. And these tests are really useful for me as an addiction provider. I use these tests all the time because I'm the provider managing my patient with a substance use disorder. I'm seeing them for many visits. I'm the one prescribing their medications for substance use disorder. I'm the one getting them into behavioral health therapies, et cetera, et cetera. And so, yes, I will get these tests because they do change my clinical practice as a provider. If you don't need to get a drug test for a patient, don't get it if you don't need it. That's one recommendation. The second recommendation I would give is that you should never get a drug test from a patient without his or her consent. This is extremely important because unfortunately, because of the way that substance use disorders are addressed in the community and in the legal settings, the results of these tests can get into the hands of people who are not medical providers and do not know the inherent limitations of these tests. For example, false negatives and false positives. And I have seen the results of these tests and potentially even inaccurate results because it was based off an immunoassay test be used for a patient and completely change her life, put her back into jail, take her children away, things like that. And so you really make sure that you are not getting these tests unless you get consent from a patient, so that patient knows, okay, this test is on file, I know what's going on, and they're aware of what's being done for them. If you do get a test after you get consent from a patient and you find anything in your test that's inconsistent with the patient report, so if the patient says she wasn't using cocaine and she has cocaine on her immunoassay test, you should always send it off for a confirmatory test, also called a definitive test, a send-off test, chromatography, or mass spec, different words for similar types of tests. These tests are definitely needed whenever the immunoassay test that you get is inconsistent with the patient report, because you really need to make sure that you're getting accurate results, because again, you didn't order the test unless you needed it and it was going to change your clinical practice. And then also because of the limitations and the ramifications that these tests can have for patients outside of the medical setting, unfortunately. Okay, next, we've done our universal screening with a validated tool in a non-judgmental, compassionate way. And let's say then we're going to go on to assessing our patient. So further assessment of their substance use to see where do they fall in this risk pyramid. So how do you do that? Well, you need to proceed with further assessment in order to, again, see where your patient falls in that risk pyramid, because that's what determines what type of brief intervention you do for that patient while he or she is in the office. There's different ways to do this. For drugs, that NIDA assist tool that I showed earlier, like I said, if a patient starts to screen anything other than never for the past year use of one of the substances, it'll open up into a longer questionnaire. And with that, you'll get these scores. And so they'll spit out a green, yellow, or red score to show if your patient's at low, moderate, or high risk. And what I do like about this tool is that based on the risk category that your patient fell into, then that will also spit out resources for your patient, or spit out resources for you. It'll give recommendations for how to manage that patient and also deliver the most appropriate brief intervention for that patient. Let's say that for some reason you're not using one of these validated tools. You should always just make sure, again, after you've done your screening, talking about patients with their substance use in a non-judgmental way, then you need to further assess the patient if they screen positive on those shorter questions about how that substance use is interfering with their life. The important things to know is that how is that patient controlling how much substance use they're having? When they have 1 or 2 beers, are they able to stop using that? Have they noticed any harms related to their substance use? Have they noticed that when they use their substances, that it leads to their depression worsening and that puts their mental health at risk? And maybe they've had suicidal ideation or ended up with a psychiatric admission, something along those lines. So just trying to see, gosh, how risky is this level of substance use that my patient has? The other thing to make sure that you assess is just, does your patient have any other reason why pretty much any substance use, large, small, etc., is especially harmful for your patient? Obviously, pregnancy, young age in the teenagers, certain medical conditions like liver disease, and if your patient's in recovery from a substance use disorder. And so it's important to know those comorbidities about your patient or those other life circumstances, because those in particular too are very important to know. Gosh, well, even if they're down here with their level of use, it's still very risky given what I know about their medical history. Okay, so let's see that you did your further assessment of your patient with their substance use, seeing how problematic that use is, if it's getting in the way of them of their daily activities, and you found that your patient is low risk, that your patient has no past or current use, or they've stopped their use, for example, and this is a pregnancy example here. So for that, for the brief intervention, you're going to offer brief advice, maybe give them a written handout. And also, I would recommend reinforcing healthy habits. So there's lots of different free handouts. You don't need to go making one for your practice. These are some of my favorite websites that I like to go to that my nurses and I use in order to provide some patient handouts, also provide some education to patients. We give some of these, especially this Rethinking Drinking here, the smokefree.gov. This Women in Alcohol brochure here is great for patients and providers. And again, these are a couple other examples for smoking. I know that's outside what we're talking about today, but there's a large correlation between tobacco use and other substance use. And so again, I use these resources to give it to patients who maybe have low levels of use, or if they're not using at all or extremely low levels of use, I'll use these resources too to reinforce healthy habits. Okay, so let's see that you did your screening, you did your further assessment of your patient's substance use, and you find that he or she's at moderate risk. So that would be maybe high use of the substance in the past, maybe treatment in the past for a substance use disorder, or maybe continued low levels of use of a substance that still does carry significant health impacts. Well, for that patient, you're gonna gotta amp up. So the difference between all of these bubbles here is that they all kind of compound on one another. So you're going to use brief advice and handouts and such down here. Then the yellow here, you're going to do all that and also tailor a brief intervention for your patient. Maybe include some motivational interviewing and, extremely importantly, follow-up visits, frequent follow-up visits with that patient. So if you're thinking, gosh, motivational interviewing, maybe I need some brushing up on that. I feel like as providers, we do motivational interviewing all the time, but sometimes we get rusty, especially if we're not talking about more sensitive topics in the motivational interviewing with our patients. And sometimes it's good just to have some dedicated one-on-one time to brush up on our skills, to be able to offer the best motivational interviewing and brief interventions for our patients while they're seen in our exam rooms. This is one example from the American Society of Addiction Medicine. These are some screenshots from their website, just again showing that there are free resources online too for you to use for this purpose. And so let's say that your patient screened positive, and then you further assess the substance use and it was high risk. These are going to be patients who very likely would meet diagnostic criteria for a substance use disorder or for unhealthy levels of substance use. And so for those patients, you're going to talk to them, give them handouts, do a brief intervention with motivational interviewing, definitely schedule a follow-up visit that's in short intervals from the one that you're in with the patient that day. And then in addition to that, you're going to see how I can give a warm handoff to a treatment provider if I'm going to refer that patient out, and also see how I can initiate treatment right here and now for that patient who likely has a substance use disorder. And so one example of how to do that, let's say that you have a patient with who screens positive, high risk for an opioid use disorder. Well, and then you talk to that patient more, and let's say that, maybe it's a good day and that patient really wants to start treatment. Well, number one is that you can make sure to get your X waiver so you can initiate buprenorphine in the office. And there's lots of great resources online to help you with that. PCSS.org is a great resource with free trainings for providers. It's very much focused on buprenorphine management for opioid use disorder and equipping us as primary care providers and those providers providing preventative care and to initiate treatments for substance use or opioid use disorder. And let's say that you initiate your treatment for opioid use disorder, you get that patient started, but you just don't have the capacity in your practice to hold on to that patient for continued opioid use disorder management. If you're unable to do that, then that's okay. At least getting it started and giving a warm handoff to another provider is of utmost importance for this very high-risk patient population. There is an app by SAMHSA, or the Substance Abuse and Mental Health Services Administration. These are screenshots, again, from my iPhone of the MAT app showing where you can find other providers near you. You can put in the zip code that do prescribe buprenorphine. Okay, so now what we're going to do is we're going to run through SBIRT one more time, thinking about it in the context of a patient that you're seeing in your office who maybe has a risky level of alcohol use or likely has an alcohol use disorder. Now, first, I'm not going to go into ad nauseum why alcohol is so important. I already showed some great epidemiology from recent numbers from the CDC at the beginning of the talk, just showing the impact that alcohol is having on our patients across all different groups. And so again, not going to hone in the point, but alcohol use is extremely important and continues to be the most common substance use disorder among people who have a substance use disorder. There's this misperception I find, for example, by my residents. They see so much opioid use disorder just because we're a referral place for that. So they think that opioid use disorder is the most common substance use disorder among reproductive aged women, for example, the population that we see. But I have to remind them all the time, it's an alcohol use disorder that is the most common substance use disorder among people. But unfortunately, it's the substance use disorder that people, including reproductive aged women, are least likely to get treatment for, or at least evidence-based medication treatments in particular. So again, so important to make sure that we're applying SBIRT, not just for drugs, but also alcohol. So there's this great document that I'm going to be using to go through our example of SBIRT for risky alcohol use, and it's free. It's here, and this is the website. And there's actually some great handouts in this document for providers and also for practice level. So how do I, as a practice, implement better and universal screening, brief intervention, referral to treatment for alcohol use? And I really like the handouts and kind of the worksheets that they have to help support providers and practices in doing so. So this is what we're going to go over. So you have your patient, then you're going to first assess their alcohol use, then you're going to you're first going to screen their alcohol use, then you're next going to assess their level of alcohol use, and then you're going to risk stratify them in order to tailor your brief intervention and referral to treatment if they need that. So here's our handy dandy SBIRT pyramid again. So let's first go over the screening for the substance use. So just like when I went over earlier, there's lots of screening tools. And again, screening for a substance use disorder is best done using a validated tool that involves a patient and provider conversation. There are lots of screening tools. I would say that my favorite is the Audit C. So the Audit C here, and here's the Audit C questions. I like this one because it's one short, so it's easy to do in my 15-minute visit where I'm expected to do a million things in. I like it too because it's there's a different scoring system for males and females, so it's sex informed, and I do appreciate that given the differences in how alcohol use and impacts, especially based on level of drinking, males and females. And then 3, I also like it because it does pretty well in pregnancy too. So if you're not going to be able to overhaul your screening practices and your EMR, for example, or your practice level with pregnant and non-pregnant screening tools like I've showed you already, you can at least keep this one in there, and it's going to work pretty well for the pregnant people too, as you can see here. Let's say that you were unable to implement the Audit C in your practice, even though I think it's a really good one. It's only 3 questions, and you can put it on your new patient paperwork, put it in your EMR, make a dot phrase. You can use single questions for this initial screening. So asking something like, How many times in the past year have you had 4 or more drinks in a day for women, or 5 or more in a day for men? So asking about those unhealthy levels of substance use or alcohol use. And the other question you can ask is, in the past year, how many times have you had more than 4 alcoholic drinks on a day? In addition to that, you can also ask about tobacco, drugs, and non-prescribed substances. So again, using a single question is also okay too when you're assessing for risky substance use. But please make sure that if you're using a single question and you're not using different validated tools that we know work in pregnancy, and you have a pregnant patient in front of you, please, please, please make sure that you ask your pregnant patients before you knew you were pregnant or before you knew about the pregnancy, how many drinks, blah, blah, blah. Or how often did you use other types of substances? So just making sure you're assessing pre-pregnancy or pre-recognition of pregnancy substance use first. The next thing is that, especially for alcohol, it's so important to use clear language. Alcohol is a little bit tricky because there are definitely categories, and these are these great diagrams from that document that I showed earlier of showing how much drinking is too much drinking. But please make sure that if you are talking to a patient and she says, oh, I have about 3 drinks in a week, please don't say, okay, and then write it down, because her 3 drinks might be your 7 drinks based on accuracy of how much is in a drink. How much alcohol is in a beverage counts as a drink in your calculation of unhealthy versus healthy or low levels of alcohol use. And something you can do is that there's calculators online. So this is that Rethinking Drinking website I showed earlier, and this is a screenshot from one of their pages, and they have all these different tools that are really nifty. One of them is the drink size calculator, the cocktail content calculator. So essentially you can do this with patients, pull it up in the exam room and say, okay, well, how much do you drink? And okay, let's put that into this calculator and see how much alcohol that really is. So both of us can be on the same page with our language about how much you're drinking, and make sure that we're taking control of your health. So let's say you did your screening, maybe you used the audit C, the 3 questions that we went over earlier. Now you're going to go into further assessing the level of alcohol use to place your patient into the appropriate risk category. So I showed earlier the NIDA Modified Assist, which was that screening tool, which is free online. And I showed those screenshots from my phone, and that's that works very well for drugs. For alcohol, the audit actually is quite good too. So I showed earlier the audit C, which has the 3 questions, which is great for a screening tool. If your patient screens positive on that, then in order to then further define their level of use and further assess it to see where they are on the risk pyramid, you should go on to the full audit 10, which is right here. So it's a longer questionnaire. The reason why you don't need to do this for every patient if you don't want to is because it's quicker to just do the audit C and then only do the audit 10 if a patient screens positive on your initial audit C. But again, like I said earlier, if you are unable to do these validated screening tools and integrate them into your EMR or into your new patient paperwork or into the provider interview, etc., for right now, at least making sure you're asking non-judgmental questions. And when you're at this assessment stage, making sure you're asking patients about how much their drinking is harming their health and how much they're able to control their drinking. Like these questions 4 and 5 here. How often during the last year have you found that you were not able to stop drinking once you started? And then how often during the past year have you failed to do what was expected of you because of your drinking? So those are 2 examples from just the audit 10 that are really trying to get at that continued use despite adverse consequences, which is the definition of a substance use disorder. And then lastly, like I mentioned earlier, it's very important to assess any medical reason why any alcohol use would be harmful to your patient. Pregnancy, young age, certain medical conditions like liver disease, and of course, if your patient's in recovery for a substance use disorder. Again, just saying, well, gosh, even if they're below those 3 drinks in a day or below the 7 drinks in the week for a female, for example, I think that any level of alcohol use might be risky for my patient in front of me, knowing her medical history. Okay, so let's say that you did your full assessment of your patient's alcohol use, maybe using the audit 10 with those different cutoffs that I showed, and we found that your patient is in the low risk category, which is so lovely. Well, like I mentioned earlier, what I typically do in this situation is I reinforce healthy habits. So I tell patients about what are considered healthy and non-healthy levels of drinking. And I tell my patients, the recommendations say that women should not drink any alcohol or have less than 3 drinks in a day or 7 drinks in a week. Or I also show them what are the guidelines here, as we can see, for the levels of drinking that are considered healthy and unhealthy. And then I say, gosh, it's really great that you're within the healthy levels of drinking that we have as recommendations from the CDC and other professional societies. And I found that my patients really like it. They like it when I say that they're doing a great thing. They like to hear that there is a criteria, there is a level of drinking that's unhealthy, and I'm below that. Everyone likes to be reinforced in the positive behaviors that they're doing. And so I take this opportunity to do that with my patients. And you never know how it's going to help them in the future for their health, or maybe someone of their loved one's health. Okay, let's say that you assessed your patient's drinking levels, you assessed them and you found out that, gosh, I think they're at moderate risk. Maybe they're having some trouble cutting down on their drinking or stopping their drinking when they start drinking. Or you find that they say that the drinking interferes with their job or their relationships, but they still continue to drink at times. Well, that would put that patient definitely at least at moderate risk. What do you do here? Well, this is really where a true brief intervention comes in, and motivational interviewing is at the core of that brief intervention. This is not a talk on how to do brief interventions. I'm just showing you some snapshots from that document. I already showed you some great resources earlier from the ASAM website, the American Society of Addiction Medicine, the PCSS website.org, where there's a great resources too that are free for providers, that some of them also cover motivational interviewing. But this is the time to start thinking about how you're going to integrate a really good brief intervention for your patient. And like I said, you can take, these are examples from that document I have, just asking patients open-ended questions. Like, what do you make of that? After you kind of repeat to them how they scored on the audit, or how they did on the screening and assessment tool that you use. Again, giving that reflection back to patients can be really powerful. A lot of patients don't know that the level of drinking that they're doing is not good for their health. So using tools like these that are screenshotted here can be really helpful to help open up a conversation with your patient. And there's been studies to show that these types of brief interventions, they don't seem like a lot, but they really can have significant positive impacts on your patient's health. And so these are some more examples of how you can talk to your patients in an open-ended way. So talking to them, rolling with resistance, talking about the positives and the negatives of drinking. I know it's so hard for us sometimes to say, well, what do you like about smoking, or what do you like about drinking? When we know in our head we're talking to them about the substance because they have an unhealthy level of substance use. So again, sometimes it puts us as providers into an uncomfortable situation, but this is the key to motivational interviewing, and it really does work. So let's say that you assessed your patient and they actually are at high risk, and you're concerned that they may have an alcohol use disorder. So like I mentioned earlier, these patients in red are going to need everything from these 3 bubbles: talking to them in the office, providing some informational handouts of some sort, some good websites, doing a really thorough brief intervention with motivational interviewing, scheduling them for a very close follow-up visit with you as the provider who talked with them and that patient was willing to open up to you about their alcohol use. But in addition to that, we should really think about how we can initiate treatment now if the patient is treatment ready, and then give a warm handoff to a treatment provider if it's not going to be us in the office. Now, again, I don't have to go into all the importance of this, but again, unhealthy alcohol use can have significant health impacts in both short-term and long-term that a lot of patients just don't know about. And even if they do, if they have an alcohol use disorder, may continue to use unless they have an intervention. So if you have a patient who is willing and desires to start treatment, that is a big deal. The number one reason why people with a substance use disorder, according to national level data from SAMHSA, that they don't get treatment is because they weren't ready. They didn't think they needed it yet. And so if a patient comes into your office and he or she says that they want to start treatment, you take advantage of that. That is not a patient you say, okay, great, well, I'll see you back. Well, why don't you schedule an appointment next week and we'll talk about more then. No, that is a time where to maybe go over in your clinic schedule a little bit, ask your colleague to see one of your patients and get this patient started on some type of treatment, because this is a huge window of opportunity that does not occur very often. So we as providers, if a patient feels comfortable enough to talk to us about their substance use, we really need to honor that and also be comfortable with on our own side of talking to them about treatment. And so let's say that you've completed your ESPR and you took those few extra minutes like I just mentioned. You need to make sure you bill for your brief intervention, okay? Because even though it can only take about 5 minutes or so, or then sometimes you take longer, about 15 minutes. And so you do need to make sure that you're billing for this so you can make sure that you can continue to do this very important practice in your general clinical practice. And these are some examples of the codes that you can use for billing purposes that are also available at that website that I showed earlier. Okay, so let's say that you have your patient in the office and your patient screens positive for a substance use disorder. You further assess that patient and definitely meets, you are concerned meets criteria for a substance use disorder. And let's say that your patient desires treatment. Gosh, what do you do at this moment? Well, what we're going to go over is some outpatient substance use disorder management to help equip you as a provider to not just screen, assess, brief interventions, but also initiate treatments and get patients on the right path. So just before we start, there are some general substance use disorder treatment principles that we do need to go over. We already talked about how the step one is to assess the severity of your patient's disease. So how severe is your patient's substance use disorder? And so in doing so, and we'll go over how to do that, you do need to then make sure that you're putting your patient at the right level of treatment. So this is the ASAM level of care here. So it goes from 0 all the way to 4. And we are here, outpatient services. This is where I am. I run an outpatient program. And so it's very common that patients are not going to need, that outpatient services are not going to be appropriate for that patient at this moment in time, for example. I have many patients that maybe start treatment with me here, but go through a period of time where they need to be in some type of residential treatment over here, but then can go back to outpatient treatment, or vice versa, need to start over here in an inpatient unit and then go to an outpatient unit thereafter. And so I can't say this enough. It's very important that when we're thinking about substance use disorder treatment, that we think about it as multimodal, we think about it as person-centered, and we think about it in an individualized fashion. And that's easy for us to do as providers because we treat individual people. And so thinking about where your patient lands at this one period of time on the level of care continuum is extremely important to make sure. And then again, we need to ensure that harm reduction principles are being utilized throughout wherever that patient is on the spectrum of care. And so if you have a patient outpatient services at the outpatient level that you think needs to go to residential treatment and that's your recommendation, but that patient says to you, I just can't do that right now because maybe that patient just got a new job and that job is so important to their financial security and also to them reaching their recovery goals. Well, that would be great if that patient would go to residential treatment at this time, but the patient doesn't want to and can't and isn't going to. So what can we do at an outpatient level to maximize what they're getting out of outpatient treatment, not just for their disease, but also for their life? And so ensuring that they have naloxone at home, making sure that you're seeing them for frequent visits, getting them into medication and behavioral health therapies, maximizing what we can do at the outpatient level. And just saying, even though I recommend this right now, I'm not going to kick you out of treatment because that treatment right there could still be life-saving. And that treatment is better than no treatment, even though it may be at that point in time, that's where the patient should be. So I know that ends up being a hard balance sometimes, but we do have to remember that there are recommendations or there are these different levels of care. But when it really comes down to it, we really need to model and shape our care plans for our patients to their individual needs. So let's say that you did your screening and your assessment and you find that gosh, I'm really worried that this patient might have a substance use disorder. How do I diagnose them with a substance use disorder? Well, you use DSM-5 criteria for that, and they're all listed right here. And so what happens is that after you see where your patient lands on these DSM-5 criteria, and these are all yes or no, then you put them into mild, moderate, or severe. And just of note, you do need to document if you are managing a patient for a substance use disorder in a clinic, you do need to document which of these levels they are for billing purposes. So most of my patients, for example, for opioid use disorder, most of my patients are severe, and on buprenorphine when I'm seeing them. Something that's important to know is that you don't need to ask the patient all of these questions. I've noticed sometimes I'm laughing a little bit because my residents, when I teach them this, I forget to tell them that they don't have to ask these questions, and they sound kind of awkward sometimes. But what's important is that you can actually get the answers to most of these questions just by having that non-judgmental, open, comprehensive conversation with your patient when you're talking to them about their substance use, kind of like what we talked about earlier on the assessment part of the pyramid. Then, of course, if you get to the diagnostic part with DSM-5 criteria and you find that, oh, I really didn't get this one question from their history, then you can go back and ask them about that specific question for the DSM-5 criteria. The other thing that's really nifty and great with DSM-5 is that these same criteria apply for all substance use disorders, alcohol or drugs. So it does make it a lot easier for us as providers to keep track of things. I have a dot phrase with all of these things and then with the assessment over here. And so it's really easy for me to do this in my outpatient practice. And I give it to my residents to use when they see patients on the inpatient or outpatient sides also. So they're also equipped to see where this patient lands on the severity of their disease and for diagnostic purposes, so we can make sure we get them into the appropriate treatment if they desire treatment at that time. Like I mentioned earlier, substance disorder treatments do need to be tailored to an individual's needs. And so we really need to think about substance disorder treatments as this really complicated diagram here. Just like the disease of addiction has come from a multitude of risk factors, psychosocial, biological, genetics, etc. We need to also shape our treatments in the same way too. It makes sense, right? If we just do one of these things in the middle, we might not be able to actually help that patient achieve the recovery goals that they want. And so in doing so, we need to make sure that we include a few extra things. So making sure that the treatment is tailored to their individual needs, sexist to their sex or in their gender, that there's medications, if we have medications for their substance disorder, at the cornerstone, at the crux of the treatment plan. And we need to make sure that we're providing the robust support and psychosocial and wraparound services that our patients need. For example, many of my patients are pregnant or parenting. And so we have wraparound services that are tailored to parenting people, things that have to do with childcare, infant care, things that have to do with maternal attachment, all those types of things that we know can help bolster our patients' support and therefore their success in their treatments. And so we're going to have those in our practice because that's what our patient population needs for a lot of them. And then, like I mentioned earlier, substance use disorder is a chronic medical condition. And so it's important to remember that just because a patient uses a drug again after they started treatment with you, doesn't mean they need to be kicked out of treatment. You wouldn't have someone with diabetes, for example, in your office who you started on insulin and metformin, and then they come back and their sugars were through the roof the last week because maybe they fell off their diet. That happens. A patient has a really stressful situation, a family member died, they lost their job. It's normal for there to be ups and downs in a chronic disease. You wouldn't say to that patient, well, I'm not going to give you your insulin because you did a really bad job with your sugars last week. We should not be doing that with addiction. It is a chronic disease, just like all these other medical conditions that we are very well versed with as preventative care providers. And so, for example, I don't use the word relapse, right? I use the word recurrence. I say a patient has a substance use recurrence that happened. And so when a patient has a substance use recurrence after you started treatment, which again should not be the exception, it should be the norm. Of course, we're hoping as providers that we're helping support our patients in decreasing recurrences as much as possible. But we need to remember that is going to happen, and it's normal when a patient is dealing with a chronic disease for there to be ups and downs. So we should never discontinue treatment after a patient has initiated treatment with us because they use drugs again. But if a patient continues to have recurrences of their substance use after starting treatment, we need to then tailor what we're doing for that patient. So just like if you have a patient with diabetes, like I mentioned earlier, You started them on a treatment plan, maybe some insulin and metformin and a diabetic diet, and they come in and they're just not doing well, then you would talk to them, right? You say, gosh, what's going on? You know, you would get them in with a diabetes counselor. You would change their medications around, have more frequent visits. Maybe they can't afford their medications. They're having trouble getting to the pharmacy to get them. We all know we deal with this on a regular basis. We really need to treat addiction in a very similar fashion with increased support and increased frequency of provider interactions when a patient is not doing as well. And then also, in addition to that, like I mentioned earlier, there are different levels of care for addiction. So you might have a patient who's been doing great in outpatient management with you, but maybe starts to go through a really tough time because of some social stressors that just led that patient down a path to multiple recurrences of use and is having difficulty kind of getting out of that cycle. That patient may benefit from going to a residential treatment program or an IOP, intensive outpatient program, for a period of time and then come back to you. Just like someone with really bad diabetes might get DKA or get really sick and have to go to the hospital for a few days, and then we'll come back to you in clinic. So again, tailoring our treatments, and we need, us as preventative care clinicians, we're actually really good at chronic diseases. So we need to really hone in those skills that we have at supporting our patients in their health goals when they do have a chronic medical condition. And then in doing so, we do need to make sure that we are implementing harm reduction principles throughout the continuum of care for our patients. Like I mentioned earlier, you know, addiction, how addiction it becomes to be, and for a patient, comes from multiple different sources, things from that they were born with and things with their environment, and they all kind of intermingle and lead to this disease. When we need to tailor our treatments exactly the same way in a multimodal fashion, and figuring out which bubble of the treatment that I really need to emphasize at this point. And I went over earlier how harm reduction is extremely important for all these patients, especially because for our patients with substance use disorders, a recurrence of use can be deadly. I showed all those terrible numbers at the beginning of the talk of all these drug-induced deaths that are occurring and these alcohol-related deaths that are occurring among young people for the most part. And so we do need to make sure all our patients have naloxone at home, and we're helping them with all these other things that we know impact their disease: intimate partner violence, housing instability, unsafe housing, and stigma, which includes discrimination and shame from people, from the community and people's own family members. These are really just examples of things that I see every day in my practice that I know for a fact are impacting the health of my patients and their ability to get the best health outcomes out of the treatment plan that we've discussed. So what are all these treatments I keep on talking about? Well, there are different components to evidence-based substance use disorder treatments. And so I try to think of it in this very simplistic triangle here. At the core of substance use disorder treatments are going to be medications. They use another word that you might see thrown around is pharmacotherapies. And those are going to be delivered by a medical provider. For example, the most common example is going to be methadone or buprenorphine for opioid use disorder. And so I put them in the middle here because if you do have medications for your substance use disorder, and I say that because not every substance use disorder has a medication that's been FDA approved, it should be at the crux of what you're offering to the patient. And so in addition to that, there are many other behavioral health type of treatments that really do also improve outcomes for patients. They can be individual therapies that are delivered by a licensed mental health professional. Group counseling or group therapy sessions are a big cornerstone of substance use disorder treatment. Then of course, AA and NA and other peer recovery support play a huge role in helping a lot of patients and a lot of people, and a lot of individuals with substance use disorders reach their recovery goals. But what's very important to recognize is that today we're going to be focusing largely on the medications, and we're not going to be going through all these other components. And it's just because that's the focus of the talk today, but all of these work together in different ways. And for different patients on an individual level, they're going to have different combinations of these things that work for them. And you really need to help patients, support patients, and they're figuring out of, gosh, how do I put the puzzle of all these different treatment options together for it to work best for me? And so a big thing to recognize is that like I mentioned, if you do have medications for your substance disorder, like alcohol or opioids, like I mentioned, behavioral health therapies are great And you should definitely offer those to your patients, and you should definitely make them available to your patients, and you should definitely suggest them to your patients, and you should help support them as they try to access their treatment. So if they need childcare, transportation to make it to their therapy visits, offering telehealth options, things like that, you should definitely make sure that those are in your practice. However, what you should not do is make it required for patients to be engaged in behavioral health therapies in order to receive medications. And that is not evidence-based. This is one paper that I bring up here that was published in JAMA not that long ago, looking at different types of behavioral health therapies, such as CBT and other evidence-based therapies, and seeing, gosh, when I combine them with medications for opioid or alcohol use disorders, what happens? And what they found is that the addition of these therapies with medications for the substance use disorders that we do have medications for, it does help. There's a small improvement, but it's very heterogeneous. So not all patients are going to have a great improved response when you add those types of behavioral health therapies to their medications, where some patients will. And so the reason why I bring up this paper is just to hone in the fact that you should never require behavioral health therapies for patients who are receiving medications for substance use disorder. We should definitely offer them, suggest them, make them available, but don't make them necessary. I have lots of patients who are on Suboxone or buprenorphine for opioid use disorder and don't engage in behavioral health therapy and do great. Whereas I have other patients who are on buprenorphine for opioid use disorder and are also in counseling with one of our licensed mental health professionals. And I would say that that counseling is definitely the biggest thing that's helping them in that moment. It seems like a lot of time. And it's a team effort. And so I know that patient does a lot better when they're in the counseling in addition to their medication than when they're not. But again, you really need to see what works best for your patient and support your patient in trying to figure out and do some of the trial and error that sometimes has to happen to get to that right treatment plan. So like I mentioned earlier, the focus of this talk is we're going to focus the rest of the presentation on what are these different medications that we have for alcohol, opioid, and stimulant use disorders. We're not going to go over all the different types of behavioral health therapies, but I just want, and it's not because they're not important, it's just not what we're going to be focusing on today. So let's first start with alcohol use disorder. So let's back up a little bit and talk about how these medications work. And they're going to go over some broad categories of how alcohol use disorder medications work. But to tell you the truth, it's kind of going to apply to all other types of medications that are either being investigated now or have been approved for even other types of substance use disorders. There's generally 4 different methods. The first is a medication that's going to block or reduce the positive reinforcing effects of the substance use. So that euphoria or the positive effects that can occur with the substance use is going to block those effects. The next way is that it's going to reduce the negative reinforcement or the reward that is generated by the removal of the painful or stressful conditions. So essentially like detox management or withdrawal management is an example of that. And then the other ones are going to be talking about aversive response or conditioning. There's other medications that may have that in combination with one of these other methods. But the most common one that we talk about are the ones that reduce cravings for these different substances like alcohol. What is a craving? Well, a craving is going to be the urge to drink alcohol, the learned anticipation of drinking alcohol. So if alcohol is put in front of them, having that craving come up, or spontaneous cravings. So which patients are candidates for alcohol use disorder medications? Well, of course, it's going to be the patients that meet DSM-5 criteria that we already went over. And here's a snapshot over here of some of the questions from DSM-5 for alcohol use disorder. Also, it can apply to patients who maybe don't meet alcohol use disorder criteria necessarily, but have heavy drinking days and risky levels of alcohol use. You can also consider it in some of those patient situations too. But it'd be important in that situation to make sure to continuously assess your patient for falling into that use disorder category or not. And so it's also going to be for the patient that wants to reduce their alcohol use, right? A patient's not going to take a medication every day if that patient doesn't want to reduce the alcohol use or reach abstinence. And again, like I mentioned earlier, we also need to make sure that we're offering psychosocial supports and behavioral health therapies to all of our patients who are receiving medications for alcohol use disorder. So what are the outcomes of medications for alcohol use disorder? Well, of course, we're trying to prevent the alcohol use disorder from getting worse. We went over how there's different severity levels for alcohol use disorder. We're going to try to prevent the consequences of alcohol use disorder or heavy drinking, prevent the frequency of alcohol use, recurrence, and we're going to try to reduce the long-term morbidity and mortality. So all those terrible numbers I showed at the beginning of the uptick in alcohol-related deaths, mainly liver disease, that has been occurring for many generations in men, but now in women it's starting to skyrocket, reducing that. And then also, but I would say most importantly, because this is what's really going to help a patient sustain outcomes over time, is making sure that we're offering patient-centered care and asking patients, what are their goals for recovery? What are their goals for being on this medication? And how can we help you get to that? And so there are definitions of what recovery means, and it's not just abstinence. It's not just reduced alcohol or substance use. It's also helping support patients in their other goals, like getting a job, you know, being the parent they want to be with their children, or the partner they want to be with their partner, things like that. And so we need to make sure we're assessing what our patients want in treatment too, because that's going to be the best way for us to not only help them achieve those goals, but help keep them in treatment too longer term, so they can optimize the results of that treatment plan. So what are the options? Well, there's 3 FDA-approved medications for alcohol use disorder that we're going to go through: Naltrexone, acamprosate, and disulfiram. There are other non-FDA approved options that do have some evidence to support their use. We're not going to go into those today. This is a snapshot of that same website I showed earlier from our expert part of our talk. And there's a section in here for patients that talks about the different medications for alcohol use disorder. So you can also send patients to this website too if they want to read more about it. So let's first go over naltrexone. Naltrexone is an opioid receptor antagonist. So we're going to talk about it again when we get to opioid use disorder. How naltrexone works generally is that it modulates the dopamine transmission, or that reward system in the brain. It reduces cravings and reduces the positive reinforcements of the alcohol use. It's very efficacious. It's been studied many times and meta-analyses have been done. I would recommend this as the first-line option for your patients. I have a lot of patients on naltrexone for their alcohol use disorder. The number needed to treat is really good, especially compared to some other treatment options that we have for other medical conditions. And again, the outcomes that have mainly been assessed in the clinical trials have been reductions in heavy drinking days and recurrence of those after patients reach abstinence. Naltrexone is in a pill form, but it's also in an injectable form. The pill form is generally 50 milligrams a day. Sometimes for patients with sensitive stomachs, I'll start them on 25 milligrams a day. And then you can start it while the patient is still using alcohol, or if they're at the kind of starting in the beginning of the abstinence stage, you can start it then. There is a monthly injection of the naltrexone, and the brand name is called Vivitrol. And so that's another option too that works very well. And it's a once-a-month shot. Some patients may need it every 3 weeks, and I found that generally insurance companies are okay with that if we do increase the frequency to every 3 instead of every 4 weeks. Again, I have some patients who their cravings come back in that 3 to 4 week time frame. Side effects are actually pretty minimal for this medication. Of course, some GI upset for the PO form. Usually those go away after a little bit. Then some other side effects that are not very common. There's very rare side effects. So of course I talk to my patients about it. I'll get LFTs at the beginning of treatment and maybe once more later on for liver toxicity, and then suicidality. We always screen patients for that. So again, but very, very rare, but is out there. The next medication is called acamprosate. Acamprosate is another, and it modulates the NMDA receptor. So again, it also works in that reward system, similar to what I just said for the naltrexone. And so reduces that rewarding effect of the alcohol use. Again, it's been studied many times and has been proven to be very effective. The number needed to treat, again, is very, very good. But generally where it's been studied before has been among patients who already have achieved abstinence. And then this is helping to prevent the recurrence of their alcohol use. Now, do I use it sometimes when patients are like right at the beginning of their abstinence stage, not really at that prolonged abstinence stage? Of course, because if I can't give them naltrexone for some reason, I'll give them the acamprosate. But just know that's where it mainly has been studied and showed to be most efficacious, is in the patients who have already achieved abstinence, and this is preventing them from having recurrence. The dosing, this is the hardest part. It is a 3 times a day dosing. They come in 333 milligram tablets. And so the target dose is 2 of those tablets 3 times a day. So a total of 666 milligrams 3 times a day. I put this pill organizer here because I have to admit the hardest part with the camprosate, it works pretty well for a lot of my patients who take it all the time. But they miss a dose or so because the half-life is shorter. You know, they'll have their cravings come back and it doesn't work as well. So you have to have a patient who's able to take their medication 3 times a day, which can be really challenging. I would have a lot of trouble taking this type of medication 3 times a day myself too. And so generally, again, side effects, again, GI upset is generally going to be something that does occur. Usually patients will get used to it, but it is something that I have had a couple patients that has gotten in the way of them staying on it longer term. Again, very rare is going to be suicidality. The last option that we're not going to talk as much about is disulfiram or antabuse. This is the medication that you probably learned about in medical school because it's the one that causes that terrible disulfiram reaction when patients do drink alcohol. It can make them feel very, very sick. So patients definitely don't want to drink when they're on this medication. So it works really well when you have a patient who is like in a controlled setting. Someone is making sure that they take medication every day. But like in real life, a patient actually able to like be in real life, it's not really does not really have proven effectiveness, which is why it says unclear here. So again, I have the dosages here. You can consider using it in very select circumstances, but for the general patient in an outpatient setting, it doesn't have clear efficacy for that patient. And then again, you can't use this medication in pregnancy. So generally, what do you do for alcohol use disorder medications? General do's and don'ts. Do make sure you check in with the patient frequently. So we have visits every 2 to 4 weeks at the beginning, and then we continue to have visits every 4 weeks or so afterwards too for our patients. Make sure that you continue to offer and make available other support services and psychosocial and behavioral health therapies. And then also get LFTs at the beginning, and then a few months into treatment, you don't need to continue checking them after that. So when should medications be stopped? A lot of people ask me this question, and for me, I always forget to say it because for me, addiction's a chronic disease. I never think about a stop date for these medications, but it's normal to think about stop dates for medications. So why should medications be stopped? Well, it's going to be if the medication is not working for the patient, which is obvious, right? So if a patient it's just not working for them, they're not taking it every day because of side effects, or they just continue to drink because of it, and they need to go to a higher level of care. And so that's an obvious one. Severe side effects, another obvious one. But in general, if patients are tolerating these medications, you should really talk to them about staying on the medication for at least a year. Because we know that they're going to have much better outcomes if they stay on their medications for at least a year. And that's been supported in the different trials that have looked at these medications. And you do the same thing for antidepressants too, right? When you're talking to a patient about an antidepressant for major depression, you also talk to them kind of around the similar time frame for that disorder. So this is very similar. And then the other thing is just to remember that you're not giving this medication to like clear up a cold or a flu, for example, or a bacterial infection. This is a chronic disease. And so the goal of giving these medications is to give patients a platform for recovery, right? To give them that support and that strength for them to go off and do the other things that they need to do to reach their recovery goals. So that takes different periods of time. Some patients are a year, some patients are many years that they need to be on the medication if it's helping them achieve those goals. So do remember that. And the other thing is that just because a patient fails a medication once doesn't mean that they shouldn't be on it again. Remember, addiction, there's lots of ups and there's lots of downs. And so I've had many patients who were on a medication a few times and didn't work, but you know what, this time it did work. And so just because a patient has not done well with a medication once or twice in the past doesn't mean that you shouldn't try it again if they're willing to do so, because this situation might be different, especially given the complex interplay that psychosocial contexts have with the medical condition of addiction, those contexts, if they've changed, might help the medication just have a better chance of success in that situation. What about in pregnancy? This one's a little bit tough because the recommendations generally say behavioral health treatments, but which I completely agree with. All of my patients are offered and suggested and highly recommended to be in behavioral health treatments. And we offer both group and individual in the treatment program that I have. And we also connect them to community-based organizations to also supplement that too. However, we know that alcohol is a known teratogen. It is the most common preventable cause of intellectual disability, for example, in people is fetal alcohol spectrum disorders that maybe were undiagnosed even at times because the patient went under the radar during pregnancy, which does happen. So if I have patients who, that behavioral health therapy is not enough right now or hasn't been in the past, and they know that medications are going to give them a better chance of success of not having recurrence of alcohol use during pregnancy, I offer them medications. And I have that classic shared decision-making model discussion with the patient that I do for all medications in pregnancy, because almost every medication is category C in pregnancy, right? We don't have any proven fetal harm, but we also don't have robust clinical trials because it's really hard to do those in pregnancy to get that gold level, that high level, level 1 evidence. But if I don't have proven fetal harm, then I'm going to talk to them about how I don't have proven fetal harm for acamprosate and naltrexone, but I do have proven fetal harm for alcohol use in pregnancy. And so do I have a lot of patients on medications for alcohol use disorder? Yes, I'm a referral specialist, so that is some selection bias there. But if a patient is going to do a lot better with regards to alcohol use, these medications are a lot better than alcohol. So please make sure that if you have a patient in this situation who needs medication treatment for alcohol use disorder, you talk to them about the risks and benefits, document that appropriately, and offer it to them. And please make sure that you try to find a provider near you that you can collaborate with too in those conversations with the patient so they feel well informed during their pregnancy and also afterwards. So like I mentioned, both of these medications, acamprosate and naltrexone, are grade C, and this is what that means down here by the FDA. And just like Zoloft is or sertraline during pregnancy, which a lot of patients are on during pregnancy, and also the kind of a similar grading too when we think about lactation. And so again, we know alcohol is not, high levels of alcohol use is not good in lactation too. So if a patient is breastfeeding and these medications are helping them not have recurrence of alcohol use, they can be continued again with that shared decision-making model, discussing the risks and benefits of that medication with the patient, and also making sure that you're getting them in with an appropriate OBGYN who's educated in this area, as well as lactation support, who also is going to be compassionate with this patient population too. Okay, next, we're going to go into outpatient management of opioid use disorder. So opioid use disorder, we also have FDA-approved medications, which is great, just like we do for alcohol. The 3 medications that we have for opioid use disorder are methadone, buprenorphine, and naltrexone. All 3 of these medications work at the mu opioid receptor, but in different ways. First of all these medications have a long half-life, so that decreases the risk of abuse, decreases the risk of diversion, and also decreases the risk of big fluctuations up and down. So methadone is a full agonist in the mu opioid receptor. So that's why you see as you increase the dose down here, you see that the opioid effect will continue to increase over here. Methadone is dispensed from an OTP or opioid treatment program and typically is dispensed on a daily basis. Some patients can get, quote, take-home medications where they can take medications home for a week or so at a time. And that's also been happening too more in the COVID-19 pandemic. Again, methadone has a long half-life, so that's very important of why it's a full agonist in the mu opioid receptor, but because of the long half-life, it still provides that stability for patients. Buprenorphine is really nifty. It's a lot newer than methadone. Methadone's been around for a long time, but it's a partial agonist at the mu opioid receptor. So as you increase the dose here, you have an increased effect, but it does reach a ceiling effect. So when you get to this point right here, this is when a patient's at opioid blockade. So this is where if they used opioids, they would have a significantly decreased risk of overdose. That's where you want your patient to be, right? To make sure that they're going to be safe if they have a recurrence of use. But you see, once they get to this point here, if they increase their dose, they don't necessarily have more of an effect. So some patients do tolerate buprenorphine better than methadone because they maybe have more side effects at the higher dose, which they might need for their craving and withdrawal symptoms, but they can have some other unsatisfactory side effects too. So that's why some patients do prefer the buprenorphine, as well as other reasons. And then lastly, there's naltrexone, which we already talked about, which is an antagonist at the mu-opioid receptor. So methadone, like I mentioned earlier, is a full agonist at the mu-opioid receptor. It's this red line right here. It has that long half-life, so you don't have the big fluctuations up and down. Patients generally will take it once a day, and they go to opioid treatment program. And when they're at the right dose, they should have no cravings and no withdrawals. And there's robust evidence to show that patients receiving methadone for opioid use disorder have much improved health outcomes. Physical health, mental health, opioid use disorder specific health outcomes are all much better. Disadvantages to methadone: every medication has pluses and minuses. Is that because of the way the methadone is stored in your body and your fat cells and such, achieving a stable dose, so increasing this dose over time to get to where they have stability from a craving and withdrawal standpoint, can take a long time. Buprenorphine is a little bit quicker. Because of the full agonist effect over here, if a patient is at their dose of methadone that works well for them for their craving and withdrawal management, if they then have a recurrence of use on top of the methadone, they do remain still at risk of the overdose. And like I mentioned earlier, daily dosing, which can be difficult for a lot of patients, childcare, employment, etc. Buprenorphine, again, is the partial agonist of the mu-opioid receptor and has that stealing effect. So you get to a point, and every patient's a little kind of different-ish on what dose it's going to be at. It typically is going to be about 16 milligrams, of where more is not necessarily better. There's many formulations of buprenorphine, which does make it a little confusing. So the combination product is definitely the most common one and is the preferred one and is the one that's covered by payers, etc. And it's called buprenorphine naloxone. The brand name is Suboxone because it has the naloxone component in it. It's called combination because it has buprenorphine and naloxone. It generally comes in these small little films here. It can also come in tabs too. A lot of patients will say, like, I don't want the Suboxone because it has the blocker in it. And so then they're referring to the naloxone. Well, the naloxone, when you take the medication sublingually, like it's prescribed, the naloxone is not really bioavailable. It sometimes can cause a nasty taste and whatnot in the patient's mouth. And so they can spit out their spit after the medication is completely dissolved and been absorbed under the tongue. But if an opioid naive patient were to crush the Suboxone and inject it, then the naloxone would become bioavailable and would protect it from overdose. So again, a lot of patients don't want this because they think the naloxone is going to make them sick and all this. That is not true. And the naloxone is not bioavailable when they take it sublingually. It's just in there as a diversion deterrent. There are single agent or quote mono products. When we say mono, it's just as buprenorphine. The brand name of that used to be called Subutex. And so buprenorphine tabs, the time when you'll give that is when a patient has a documented allergy to naloxone. And then of course there's extended release options, just like we have the Vivitrol for the Naltrexone. There's injectable products like Sublocade, that's once a month injection. We use that at my clinic here. There's also an implant that isn't used as commonly, but is an option too. Advantages, again, every medication is going to have advantages and disadvantages. Advantages, a lower risk of overdose. So when a patient gets to this dose here, usually around 16 or so, then if they were to go use opioids, they're definitely at decreased risk of overdose, which is great. Office-based delivery, so you get your X waiver, you can do this in your office. So I have an integrated clinic where we provide OBGYN care and Suboxone treatment in one visit. And so we can do that out of our outpatient clinic. Disadvantages is that, of course, we don't have as much data just because it hasn't been around as long, but the data we do have for buprenorphine is quite good, showing improved health outcomes long-term. The biggest downside is that because the partial agonist effect, a patient's going to have to be in moderate withdrawal for a traditional induction onto buprenorphine. There are some microdosing protocols that are coming out of ways that you can get a patient started on buprenorphine without them having to be in moderate to severe withdrawal. But in general, patients do have to be in pretty good withdrawal before you start it, because the partial agonist effect, it's also very sticky. So it has a very high affinity for the mu opioid receptor. So if a patient has short acting opioids or any opioids in their system, and then they take buprenorphine, it can push off all those other opioids and precipitate a withdrawal. And patients can get really sick and really upset with you if you do that. So there are ways to start buprenorphine. Again, the PCSS.org and ASAM websites have free trainings for providers to get them X-waivered, where you learn how to start buprenorphine in a safe way. But that is pretty much the biggest deterrent, because for methadone, you don't have to be in as much withdrawal for that. Now, Naltrexone we've already gone over, but again, it's an antagonist of mu opioid receptor. In order to use it for opioid use disorder, you do need a patient to be 7 days without opioids in their system. So it's not great for patients who have trouble with coming off their opioids, who maybe do have to detox first. This is not the best option for them a lot of the time. For some patients it is, but not everyone. It's good for patients who are already off their opioids for some reason. Maybe they're coming out of incarceration and they haven't had any opioids in a long time. Or you have a patient who maybe has been off any type of opioid, hasn't used opioids or been on Suboxone or Methadone, for example, for a long time, but they come in and they're really stressed out and their cravings have come back potentially. I do have some patients that have been stable and then their cravings do recur, but let's say maybe they don't want to be on Suboxone again. They want to be on Vivitrol. Go for it. And so that's just that is the big downside of that. It also doesn't work as well as buprenorphine and methadone for craving control. So it's not going to be great for your patients who maybe have this severe disease and starting treatment immediately after using. So a big thing I will talk about for opioid use disorder is that I hear a lot of the time, aren't these medications just replacing one drug for another? Won't I just become addicted to these medications after I start them? I'm not in recovery while I'm taking Suboxone or Methadone, right? And when they're pregnant, won't my baby be addicted to this drug when it's born? So these are common quotes I hear all the time and that perpetuate the stigma that surrounds medication treatment for opioid use disorder. And it's our job as providers to take the lead in destigmatizing not only the disease of addiction, but also the FDA approved and then medications that we have for opioid use disorder, which are quite evidence-based at saving lives and improving health outcomes. And so what's important to remember is that opioid use disorder medications were developed in brain science. They were developed based on what we know about the brain, just like other medications for neuropsychiatric disorders were developed, and they're not a replacement for drugs. And so just to back up a little bit, I'm going to give some context just to back up what I'm saying to help give some understanding to why these medications are medications. And we really need to make sure that we're educating others that these are not just, quote, replacing one drug for another. So addiction, just to remember, is a brain-centered condition whose symptoms are behaviors. The salient feature or how you diagnose someone with a substance use disorder is that they have continued substance use despite adverse consequences of that substance use. And just, I've said 20 times already how addiction is a chronic disease, just like diabetes, hypertension, etc. And so, but what's different about addiction than those other chronic medical conditions that it still is that for diabetes and hypertension, you have a number, right? I have a blood pressure that has a number over a number. For diabetes, I have a glucose log, I have a hemoglobin A1C, and there are certain cutoffs. Addiction is a little bit harder because we don't necessarily have something concrete with a little bow on it like that. And the symptoms of the disease are behaviors, which sometimes cause some nuances and cause some complexity versus a number that we have for a blood pressure or hemoglobin A1C. And so this is the definition of addiction from the American Society of Addiction Medicine, that it's a treatable, chronic medical disease that involves complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. And the definition also includes how the treatment options for addiction actually work really well compared to other medical conditions. And so these medications, again, like I mentioned earlier, are based in brain science. And so we know when someone reaches the disease of addiction that their brain is working differently, in particular the reward system. And so one of the theories of this is the hijack brain hypothesis. So if you think about it, if you're using a substance, cocaine, whatever it is, every time you use that substance, you have super high levels of dopamine and serotonin that can increase in your brain. And over time with that repeated substance use exposure, maybe in the context of some other risk factors for addiction, like early childhood life experiences, some abuse or other types of trauma in the past, then that patient too, with those repeated and super physiologic high levels of dopamine, the brain starts to change and the circuits in the brain start to change, the levels of the dopamine start to change, the dopamine receptors start to change to the point where the brain needs those high levels of dopamine all the time because it got used to it and it was vulnerable for some other genetic or predisposed reason. And so what happens that after those repeated dopamine exposures, the brain just wants really high levels of dopamine. And that's why you'll look at a patient and say, just stop using the cocaine, stop using the heroin. It's tearing apart your life, you're telling me. It's tearing apart your marriage, tearing apart your ability to be the parent you want to be, etc. But they don't stop. And it's because their brain has been hijacked by this altered reward response of the dopamine. And what's really important is that there's been decades of research that have backed up what I just said. We've even seen that according to fMRI studies, those dopamine receptors do change when people have gotten to the point of having the disease of addiction. And so their brain gets to the point where they just need to have those really super physiologic high levels of dopamine, which you really can't get with anything normal aside from those substances. And what also happens with all these changes in the reward system and the dopamine receptors and in the levels of dopamine that they need and in the circuitry, et cetera, is that people get to the point when they have the disease of addiction where they can't even feel the euphoria again. And they're really just using the substance to avoid the withdrawal symptoms or avoid feeling really sick. And so that's why when patients get to the disease of addiction, they get into this vicious, terrible cycle of needing to use the substances to avoid being sick and then keep on going over and over again. And that's why too, they may not, with normal things that might make you and I feel euphoric, right? Eating a piece of chocolate, being with your children, being with your family, etc. These patients maybe aren't able to feel that happiness either with those normal things too, because again, their brain is so dysfunctional at that time. So how I like to think of medications for opioid use disorder is that because they were built knowing this brain science, the neurobiological basis of the disease of addiction, and they help stabilize that dysfunctional reward system in the brain, is that therefore, when they stabilize that and they help patients feel normal, right, and they help them not have cravings and not get sick, they get out of that terrible cycle. And in doing so, they get rid of the three bubbles I think about for opioid use disorder: physiological dependence on the opioid, so the craving and withdrawal, stabilize that. And in doing so, they're less likely to misuse the opioids and then less likely to lead to all those maladaptive behaviors, right? That continued use despite adverse consequences, all those things about the substance use that have torn their life apart. And again, like I said earlier, like I try to tell my patients, is that these medications are medications. You're not replacing one drug for another. You're taking this medication every day to give you a platform for recovery, so you're not dependent on the drug anymore. And so in summary, how these medications work is that people go from feeling normal, using a drug, feeling that euphoria over and over and over again. And in the predisposed patient, they get to the point where their brain changes, that circuitry, the dopamine receptors, etc., and they continue to use just to feel normal and not feel sick. But when we use medications like opioid disorder, like buprenorphine and methadone, when they're at the right dose, the goal is that they feel normal. They don't feel the highs and they don't feel the lows. They stay right here in the middle to help them have that platform for recovery. Now, talking about pregnancy and the postpartum period for opioid use disorder management. There are important things to know for that, to tailor it appropriately for these particular patients. What's good is that there's this great document that's free online right here by SAMHSA. So if you see pregnant patients at all, or patients who are reproductive age and could become pregnant, please get this document. It's very easy. You can control F it, you can search it. There's little one-page sheets that are really useful for really referencing things. It's a very, very good document that goes over the evidence about opioid use disorder management for pregnant and parenting people. We're just going to go over some of the highlights of this very comprehensive document. And the first thing to highlight is that collaborative approach to treatment works really well for this patient population. And what's really great is that we have a lot of research going back to the 1970s showing that when you have pregnant people with the disease of addiction, when they receive treatment, they can have outcomes for themselves and their babies that are similar to people without the disease of addiction. And this is just some data from one of the original studies showing that, using low birth weight just as a proxy again for these outcomes from the 1970s. And we've had multiple studies since then showing that if you provide the appropriate treatment and appropriate care for this patient population, they can achieve outcomes that are similar to people without the disease of addiction, which is pretty amazing if you think about it. And so, like I mentioned, a collaborative approach to treatment is extremely important. Sadly, the treatment rates for people with opioid use disorder during pregnancy receiving medication treatment, and then in addition to the other support that they need, is very low. It varies from state to state, it varies from region to region. And it varies from buprenorphine providers and methadone providers that allow pregnant patients, a lot of different things. But in general, this is the gold standard of care as a collaborative approach to treatment. And this does not mean that you have to have something like I do, where we have it in one physical location, we have everything. All it really means is that if a patient needs to go to multiple locations, goes to an addiction provider, goes to an OB practice of some sort, that there's just some type of communication. There's some type of collaboration that is occurring across those different treatment groups. Now, the next thing that this document highlights is the importance, just like for non-pregnant people. Remember, pregnant people are just people who across the life course are pregnant for 9 months of their life, are the medications for opioid use disorder. And so buprenorphine and methadone are both been extensively studied in pregnancy and are both safe. No increased risk of congenital anomalies or any of that stuff. They are safe and they do achieve optimal results for both the mother and their family long-term compared to untreated disease of addiction for opioids. We used to think that for buprenorphine that we had to give the mono product, and that's just because the original trials for buprenorphine in pregnancy were with the mono product tabs or the buprenorphine tabs. And just like everything else in pregnancy, you know, we do it one time and then it's done every other time after that. And so, but since then we've had robust observational data showing that the combination product, which is the standard of care for all other patients with opioid use disorder, or the Suboxone films, is safe in pregnancy. So you do not need to switch patients who are on buprenorphine tabs or the mono product, you know, who are not on that, onto that during pregnancy. And so actually all my patients, I prescribe Suboxone, the combination product. I do not put anyone on Subutex or the mono product tabs. I do Suboxone for everyone because I know that I'm going to recommend that they continue on that postpartum, and that is the standard of care for patients with opioid use disorder. Speaking of postpartum, like I've mentioned at the very beginning with some of our epidemiology slides, is that deaths and morbidity and mortality due to substance use disorders are during the peripartum period, so from pregnancy through 1 year postpartum, are largely happening in the latter postpartum period. That is when women are the most vulnerable to adverse consequences of the disease of opioid use disorder. And so it's extremely important that if you have patients who are receiving or interested in receiving anything like that for medication treatment for opioid use disorder, that you and your practice do everything you can to help support that patient in continuing on the medication through 1 year postpartum. This is just one example, the data-driven example to hone in this very important point. My practice, we do so much to support patients to help them achieve their recovery goals through the postpartum period, which for a lot of my patients involves staying on their Suboxone. So these are deaths. These are overdose events and that were among pregnant people and postpartum people. And you can see here in Massachusetts that in the postpartum period, those overdose events skyrocketed, right, compared to pregnancy. Even though the sample size was low and the confidence intervals are overlapping, you can obviously see a huge difference between the number of overdose events among the patients who were not on their medication for opioid use disorder at that time, and then the patients who were on their medication for opioid use disorder. And so these are overdose events. These are times when a mom could die and leave her children without a mother. And so it can tear families apart. So again, doing what we can to help support patients, especially reproductive age females who desire treatment, and doing everything we can to help support them staying on that medication treatment for as long as they're able and desiring to do so. And then again, lastly, we're talking about medications for opioid use disorder are the cornerstone of treatment for patients who desire treatment for opioid use disorder. And this is the same for pregnant and non-pregnant people because we know it works so well. And so medically supervised withdrawal or detox is not recommended in pregnancy. We do recommend the standard of care, just like we do for non-pregnant people, that they are offered medication treatment for opioid use disorder and they stay on medication treatment for opioid use disorder. One of the biggest things that, in addition to stigma, that leads patients to not want to or not seek, or providers to not recommend medication treatment for abuse disorder that we know leads to optimal outcomes, is the concern for the infant. And so the concern of the withdrawal situation. And so NAS or NOWS or neonatal opioid withdrawal syndrome, the names have changed, is what it is that when any woman who's pregnant is taking opioids, their infant is going to develop a physical dependence on that medication, just like we do for patients with diabetes, either gestational or pre-existing. If they have high levels of sugar in their blood all the time, then their infant is going to know that, right? Their infant's body, and they're going to secrete high levels of insulin. And that's why those babies are at increased risk of hypoglycemia after birth if the sugars are not well controlled before birth. It's kind of a similar concept, I think of. So if a woman is taking a medication regularly, that baby is going to develop a physical dependence on that. It is not an addiction. I hope that I've honed that point in talking about what addiction is. Addiction is a chronic medical disease. It's, first of all, impossible for a baby to have a chronic medical disease because they were just born. And also, the hallmark of addiction is continued use despite adverse consequences. The baby is not able to continue using some type of substance without with adverse consequences. So again, it's not an addiction. It is withdrawal syndrome that occurs from physical dependence that developed in utero. And NAS, or neonatal opioid withdrawal syndrome, is a significant medical condition. It needs to be addressed. These babies need to be monitored, and they need long-term follow-up too. However, it is a temporary condition, and it is something that is treatable, and the frequent follow-up is treatable. But like I showed earlier, a woman who is untreated opioid use disorder is at high risk of mortality. She's at high risk of overdose. And so if you have a patient, so thinking about the pros and cons of it, that is an irreversible long-term outcome, overdose and death of a woman who is a mother and has a family, compared to NAS, or neonatal opioid withdrawal syndrome, which is also an important health condition, but it's treatable. So again, NAS, or neonatal opioid withdrawal syndrome, needs to be addressed. It is important, but it is not a reason to avoid offering patients during pregnancy the gold standard treatment, which are medications for opioid use disorder, such as buprenorphine and methadone. Now, a little bit more about NAS, just so you can make sure that you're equipped to educate your patients and provide them with the support and give them that confidence to be able to take these medications during pregnancy and know that they're safe. It generally is it's withdrawal of the infant after they're born, kind of like it is for an adult if they were to be taking a medication and abruptly stop it. Just like when the umbilical cord is cut, then the infant also can go through the withdrawal. What's important to recognize is that many studies have, observational studies have looked at prenatal opioid exposure and have tried to look at all different types of childhood outcomes, short-term and long-term. And again, like I mentioned, opioid exposure is important. We do need to consider that, and these children do need continued follow-up. But what we've noticed from the observational evidence is that probably the most significant driver of any adverse outcomes for these children are largely driven by the psychosocial context or an unhealthy living environment, and not the opioid itself. And so we do need to recognize that the opioid itself is important, but it's not the whole picture. And so again, like I said, this collaborative approach to treatment, providing psychosocial support, addressing social determinants of health and discrimination and stigma that patients and patients of color also face is very important to make sure to address, even more, I would say, than the opioid itself. And then lastly, a lot of people ask me, well, is my baby going to get NAS, or is it going to get withdrawal, or how bad it's going to be? Oh, it's really hard to tell. There are lots of risk calculators out there that are emerging, and lots of data showing the different things that increase or decrease the risk of and severity of NAS. And this is just some list of those things here. And so it's very hard to know, including things like the sex of the baby, if it's male or female. That plays a role. A lot of things you don't have control over. So it is important to make sure that we are addressing that with our patients, and we're also addressing the things that we do have control over, such as tobacco use or nicotine use. That has a dose-response relationship. So the more that a patient is smoking, that has a dose-response relationship in increasing the risk of severity of the NAS, or opioid withdrawal syndrome. So smoking cessation is so important for these patients. What does not have a dose-response relationship is the dose. So methadone, and especially buprenorphine, if you're on 24 milligrams of buprenorphine, your risk of your baby having NAS or opioid withdrawal syndrome is not higher than the patient on 8 milligrams. What's more important is that patients who are on Suboxone during pregnancy, for example, and methadone, that they're at the dose that works well for them, that keeps them in that middle box that I showed earlier where they feel normal, i.e. not at risk of substance use, either that be opioids or other substances, because polysubstance use does increase the risk of NAS or opioid withdrawal syndrome. So again, the dose, you need to make sure you're optimizing the dose, and the number does not matter, like I say to my patients, and smoking cessation. Now, breastfeeding, so even though you might not be seeing pregnant patients in your practice, you probably are seeing patients of reproductive age who are considering pregnancy, so this is very important, or patients who are postpartum, potentially, who are breastfeeding. And so there are recommendations out there saying that patients who are in substance disorder treatment, we should be recommending breastfeeding, and we should be supporting them in their breastfeeding goals. And there are some guidelines to go by, and I'm listing them right here, is that generally these patients shouldn't have any other normal contraindications to breastfeeding, like HIV. And they generally just should not be using non-prescribed substances. And like I showed earlier, substance disorder treatment works. It works really well. And if your patient is postpartum and she wants to breastfeed and she's not actively using at that time non-prescribed substances, it's your job as the provider to encourage that patient to breastfeed and reach her breastfeeding goals. Now, I'm not going to go over all the great things of breast milk and breastfeeding itself, but for these patients, for these mother-infant dyads affected by opioid use disorder, especially patients who are on medication treatment for opioid use disorder, in addition to all the amazing things that breastfeeding has for the mom and the baby, in addition to that, there's also some unique advantages to breastfeeding for these mother-infant dyads that are unique to the mom for her recovery, as well as to the baby for reduced NAS, for example. So again, this should be the default, is we should be putting these patients at the top of our priority list to help support them in their breastfeeding goals. And so patients who are receiving buprenorphine or methadone for abuse disorder, again, should be encouraged to breastfeed because we know it has all those amazing benefits and it's safe. It is very safe. These medications are excreted at such low amounts in the breast milk. We actually don't really know why breastfeeding is so amazing for these babies. Is it the breast milk itself? Is it the active breastfeeding and the skin-to-skin contact? We're not exactly sure. It's probably some type of combination of the two. But despite all these great reasons why women with opioid use disorder, including women who are receiving medications for opioid use disorder, should be breastfeeding, the breastfeeding rates are really low. These are some of the really dismal rates from even the hospital that is a baby-friendly hospital and also is a program for opioid use disorder for moms and babies. And so probably the creme de la creme, but unfortunately the breastfeeding rates in this population are very low. There's some data that's been coming out recently to show, gosh, well, why? What are the opportunities for us to intervene and improve these rates to breastfeeding in this very unique patient population? One study recently surveyed some women and found that women who did continue to breastfeed They recognized that it was important for their baby's health. So us as providers, educating them on all those things I just went over can help patients promote breastfeeding for themselves. And they were encouraged by healthcare providers. So again, giving that encouragement and equipping patients to do well. There's a big myth out there that I would ask that you try to debunk back at your practices and hospitals, that women in substance use disorder treatment should not breastfeed because they're likely to use again postpartum that will harm the baby. That is not necessarily true. Like I mentioned earlier, if you have a patient who is in treatment and is doing well and is not actively using substances, again, they should be encouraged and supported to breastfeed. This is one study that looked at women who were receiving opioid use disorder treatment with medications like buprenorphine or methadone. And what they found is that when they looked at the urine drug testing at delivery, okay, patients who had a positive urine drug test at delivery, they were at higher risk of using again postpartum. So again, a woman who is actively using non-prescribed substances, she should not breastfeed at that time. She should be supported, and if she wants to breastfeed later on, she can get lactation support for pumping it and using her milk later on in life with new milk. But for patients who had a positive urine drug test prior, right? So prior to delivery, so while they were in treatment during pregnancy, and either like a month or 3 months beforehand, even if they had a positive urine drug test then, so they had been using substances just a few months ago, but at delivery were negative for any non-prescribed substances, they were not at increased risk of substance use recurrence postpartum. So again, if your patient in front of you is not actively at that time using non-prescribed substances, because of all the benefits of breastfeeding, we really need to be encouraging moms as much as possible. And so other opportunities, if you're feeling really up to trying to get on this challenge, is other things that we can do is really face these barriers to breastfeeding that moms have told us. So moms will think that taking medication is bad and they can't breastfeed. There's a big misperception out there actually with a lot of medications. Oh, I'm taking this medication so I can't breastfeed. Actually, most medications are fine in breastfeeding. We just need to have that informed conversation with our patient. So again, equipping her and telling her, hey, yes, methadone and buprenorphine are safe to use. And then hepatitis C, there is a high prevalence of hepatitis C in this patient population. And so, but hepatitis C is not a contraindication to breastfeeding. Unless the mom has cracked or bleeding nipples, then she should not actively breastfeed with that breast. She should get lactation support in order to be able to breastfeed at a later date. Kind of like the patients I was talking about earlier with the non-prescribed substance use. And so lastly, we're at the very end. Now we're going to talk about outpatient management of stimulant use disorder. So I have to start with sadness, but stimulant use disorder does not have any FDA approved medications, just like what we have for alcohol use and opioid use disorders. And so, but there is robust evidence to show that behavioral therapy, in particular contingency management programs, are effective at treatment for stimulant use disorder. There have been a whole bunch of things that have been studied or are under current investigation, lots of different medications that you can see here, but nothing has made it to the point of convincing the FDA that it's effective enough yet for stimulant use disorder. This is a recent meta-analysis that came out looking at treatment of stimulant use disorder and looking at the different options for that treatment. And essentially they found what I just said, that unfortunately there is insufficient evidence for medication treatment for stimulant use disorder at this time, but there is good evidence for contingency management of stimulant use disorder. And we really should be considering how we can integrate that into our practices, some type of contingency management program, possibly in conjunction with your social work, case management team, and also your behavioral health clinicians if you have those available. So because of all the data out there and it's emerging, probably the best combination for stimulant use disorder, so cocaine, methamphetamines, et cetera, is some type of combination of contingency management plus medication. This is one example that came out, a paper that came out a long time ago, looking at people with cocaine use disorder, and they got citalopram and contingency management. It worked pretty well, actually. You can see that there was a significant decrease in the cocaine recurrence or cocaine use among the population in this clinical trial. However, on looking at all the data, probably the authors did say that probably what was driving most of the positive effect was the contingency management, not necessarily the citalopram. So these patients, what I try to say is these patients usually have lots of comorbid things going on. They have comorbid psychiatric disorders and possibly comorbid substance use disorders. So again, that wraparound multiple bubble care is so important for these patients. And at the center of it needs to be some type of combination of addressing the comorbid conditions. So the things like anxiety, depression, other things that PTSD that might be contributing to the stimulant use disorder, at least the continuation of being in that vicious cycle, as well as robust behavioral health therapies, plus or minus contingency management if you're able to do it. I would say definitely a plus because it is definitely evidence-based for contingency management for this patient population. But sometimes it's hard to implement that on a day-to-day basis in our practices. So to end on a positive note, though, there was a paper that just came out recently from the New England Journal of Medicine looking at, again, an example of medication treatment for methamphetamine use disorder. And this was a multi-site, double-blinded, two-stage placebo-controlled trial that looked at the combination of bupropion and naltrexone for methamphetamine use disorder. And they did two stages. So essentially in the first stage, they took everyone, they were randomized to placebo or the combination of the two medications of the naltrexone, which is the Vivitrol injection, and then plus 450 milligrams of Wellbutrin or bupropion. And then in stage 2, they took the patients who didn't really have a robust response in stage 1 and re-randomized them. That's why the numbers are different between these two stages. And you can clearly see that there was a difference between the two groups in both of these stages, more impressively in the first stage than the second stage. And so how the trial defined a response, or that was their outcome, was when they had to have at least 3 of 4 urine samples that were negative for methamphetamine at the end of both of those stages that I showed on the prior slide. And so you can see here, this is the treatment group who got the naltrexone and the bupropion, and this is the placebo group. And this is stage 1, stage 2, and then the average of the two stages. And you can clearly see here that there was a difference in the outcome. And so the difference was significant, 11% on the average, but it was quite small. So again, very motivating data showing that, gosh, there are potentially some things on the horizon. So, but this combination was statistically significant and it could argue clinically significant. But again, there was a small difference between the two groups. But again, motivating of things coming down the pipeline to help us with methamphetamine use disorder. And so to end, what is the whole point of these treatments for substance use disorder? Well, it's recovery. And so remember that recovery is helping patients achieve their recovery goals. And recovery is more than abstinence or reduced substance use. It is wellness. Okay. And what I like to tell my patients is that once they reach recovery, their brain can heal. And we do have data to show that brains can heal from the disease of addiction. It takes a while, usually years, and it takes a lot of hard work, I tell my patients, and it takes evidence-based treatments and lots of psychosocial support, but it can happen. And what's important to know is that recovery can be achieved while patients are receiving medications for substance use disorder. So my patients who have been on Suboxone for a couple of years and are doing great and, being the parents they want to be and have a job and all the things that they had as recovery goals, they are in recovery. Suboxone, again, is a medication. It's not replacing one drug for another. And again, there is no set length of time that a patient needs to be on medications or should not be on medications. I would say, again, they should continue the medications until they reach those recovery goals and get to this point where we can tell them that their brain is healing. And for most patients, that's going to be at least a year. So again, doing patient-centered care, asking patients, what are your goals in recovery? And seeing what we can do with medications and psychosocial support to help them reach those goals is the reason why I keep doing my job. And it really is a wonderful thing to do. And so if you're thinking, gosh, what can I do? What can I do? Well, I think I gave you a lot of options for things to do for screening, assessment, initiation of treatments in your practice. But the one thing everyone can do, no matter how many challenges you have on a practice level or on a management level, is to take a lead as a clinician in destigmatizing the disease of addiction. And you can do that with your language. So using person-first language is so important. Our words mean so much. We don't realize it on a daily basis, but the things we say affect everyone around us, especially when we are leaders and we are physicians. And so this is a handout. This is the reference here, and you can just Google it, that I actually give all trainees that come through my clinic. I require them to review this handout and ask me questions if they have anything, to go over what are some ways that we can transform our language to promote recovery and destigmatize the disease of addiction. So using words like recurrence of use rather than relapse, not saying the word addict, saying a person with addiction. And so a person with opioid use disorder. And so taking the stand, I would highly recommend getting this just 2-page document to help get you there. And so why is this so important? It's because stigma is the #1 reason why patients don't get treatment. It is #1 reason why patients might not continue in treatment. And it's a huge reason why patients meet all these challenges along their recovery journey. And so these are just some quotes from my own patients who completed a qualitative study recently, just talking about how stigma is terrible. And it really does negatively impact health outcomes on multiple levels. And so changing our language, changing how we practice medicine, and we implementing those and prioritizing compassion and non-judgmental care really does go a long way. And my patients have told me so. So I really appreciate your time today, and thank you very much.